Hello, everyone, and welcome to this session of the European Climate Resilient Health Systems course. This is session 3, where we will be discussing health system emergency prevention, preparedness, and response. Welcome once again, and I'm very much looking forward to an exciting session today. The course objectives, just as a reminder, are to articulate or communicate to key partners in the public the unique challenges health systems, including primary and secondary healthcare, face in a changing climate, apply methodology and frameworks for assessing vulnerability and adaptation for health systems in any context, apply approaches for measuring and monitoring the environmental sustainability of health systems and health co-benefits of transitioning to green health systems, apply a health equity lens into efforts to address health system decarbonization and climate resilience, and develop an initial plan to increase the resilience of the health system vis-a-vis the estimated climate impact on the population, and to engage the key partners to achieve meaningful adaptation. So these are the objectives covered throughout the course. As I said before, today we are on session 3, health system emergency prevention, preparedness, and response. The learning objectives for today's session are to describe how to assess the vulnerability of health systems and facilities to climate change impacts and identify adaptation options using new tools and methods. To explain climate stress testing for health systems and facilities as it relates to preparing for future climate change impacts. And lastly, to provide examples of the ways in which healthcare facilities can become more resilient in the face of increasingly severe and or frequent climate-related hazards, such as extreme weather events. A few logistics about our session. As other sessions, this is a 90-minute session. It includes expert lectures and 2 case study presentations. And we will, at the end of each session, we will have a question and answer section. Please be reminded to enter your questions for the presenters in the Q&A box of this Zoom meeting so that we can then collate everything and present your questions to the presenters. The session's recording, after we're done today, slide decks and resources will be made available on the course website for your review. As a reminder, attendance is automatically recorded during the live Zoom sessions, but your attendance is only counted if you join using your personal Zoom link. Therefore, please make sure to always log in with your personal Zoom link. Otherwise, your attendance will not be counted, even if you join using a colleague's, let's say, link. And also, YouTube views will not count towards attendance. Please be reminded that participants who attend more than 70% of the live sessions and pass the final exam with a score of more than 70% at the end of the course will be awarded a certificate of participation in climate and health from ASFER and GCCHE. And again, this is available only to the people who use the same email to register, attend all Zoom sessions, and the exam. The final exam must be completed using the same email address used to attend the Zoom sessions. The exam link will be sent to you on the final day of class via email and WhatsApp and will close on Sunday. And the format will be roughly 25 multiple choice and true/false questions, and you should be prepared to take the exam in one sitting. Now that the logistics are out of the way, I'm very excited to present to you our presenters. We have 3 amazing presenters today. The first one is Dr. Louise Elstow, who will be our main presenter for the day. And then we will have 2 case studies from Dr. Maria Libura and Stav Shapira. So I will start by presenting Dr. Elstow, who will give her first presentation. So Louise is a research associate in the engineering department at Cambridge University, working in the Center for Sustainable Development. She's part of the Life Resistal project, a European Commission-funded project that aims to support infrastructure adaptation within the European healthcare sector. Louise's research interests include climate change adaptation and resilience, contamination, and chemical, biological, radiological, and nuclear events, disaster management, societal resilience, and diversity in emergency management more broadly. She also works independently as a disaster and crisis management consultant and has worked with organizations across multiple sectors, helping them improve their operational plan, training, and exercising to respond to and recover from emergencies and disasters. Dr. Elstow, the floor is yours. I will stop sharing now so that you can share your screen.
Great. Can I just hear that you can see the correct screen, which should just be this first slide?
Yes.
Fabulous. And that also means you can hear me. So
yes.
Good morning, good afternoon, and potentially good evening to everybody on the call. I'm really delighted to be here for this third session of the European Climate Resilient Health Systems course. As we can see there, we're thinking about emergency response prevention and preparedness in the context of climate resilience. So we've covered the learning outcomes already, but just as a reminder, we're going to be thinking about vulnerability and also some of the tools that we can use to think about vulnerability and to assess the kinds of risks and hazards that we are looking at. I realise you covered some of these topics last week to some degree, so it'll be a bit of a recap if you're on that session. But we'll take a closer look at climate stress testing, so thinking about what that is and understanding how that works. And we'll also be thinking more specifically about the different kinds of adaptation that you can undertake. So thinking about proactive and reactive responses so that when an emergency happens, we're able to respond. So as Christiana kindly introduced me, I'm a researcher at Cambridge University within the Centre for Sustainable Development at University of Cambridge. That's in the engineering department. And I'm working on the Life Resistal project, which again, I think you had my colleague Gabriella on the call last week. She's from Healthcare Without Harm, and she's also one of our project partners. So I won't talk too much more about me, but just to try and hopefully indicate some of my background interests and the reason why I'm talking to you today. So, as I'm sure you're aware, the effects of climate change are likely to come in the form of floods, extreme rain, wildfires, heat waves, extreme storms and winds, and air quality issues, as well as some of the longer term impacts around sea levels rising, droughts, and water scarcity, and just general increases in global temperatures. So I'm not going to talk too much about the specifics of those, but I'm more interested in what those things are going to do in the context of healthcare systems, as well as human health. So I want to make a distinction there between the system that is looking after health, human health, and the human health impacts as well. So what we can have a look at is thinking within the context of the World Health Organization's the wheel here of their building blocks of health systems, is that those kinds of incidents and those kinds of effects will have an impact on the wider health system. So we need to be thinking in terms of adapting and making interventions, both in terms of our emergency response arrangements, but then also in terms of our infrastructures, the information we collect, our leadership and governance structures, how we train our workforce to deal with these things. So we can think about all of these things I'm going to talk to you today about in the context of maintaining those critical building blocks of the health system. So on the left there, you'll see a fairly typical overview of the changes in climate and the effects that will bring, and the health impacts, which we can think of as being around different kinds of illnesses that are caused or exacerbated by these climate effects, as well as injuries and deaths, and mental health and neurological disorders, but also zoonotic and vector-borne diseases that might have their vectors change as a consequence of climate change. When we look at that in the round, I'm going to see if I can zoom in here as well. So we can think of the secondary health impacts of climate change being things around accelerated microbial growth, survival, persistence, and transmission. So changing how the kinds of things that might cause human health impacts. We might think about changes to the distribution in diseases, where they're able to migrate to and when they're able to travel. We can also think of the impacts of changes in the environment as helping or encouraging certain kinds of pathogen multiplication, but it'll also have impact on the quality and availability of our public water system. It might have impacts on lower food production or the availability of food for certain people, the quality of the food that's available, and the prices of the food that's available, which are all going to affect the kinds of diseases that we're looking after, malnutrition rates and things like that. So hopefully those are things that none of this should be new to you at this point within the course. But as I said, I want to think about what the impacts are going to be on the health system itself as a system that is aiming to protect human health. So having a look through here, then the consequences for the health sector are many and varied, and we're going to have a look in the later slides around the difference between shocks and stresses. So some of these might be very immediate impacts and some of them might be ongoing and chronic impacts. So we'll have a think about how we can think through what those are. So I covered some of these things here, but we might also have unexpected outbreaks that we're having to manage within a healthcare setting, overwhelming influx of patients into healthcare facilities. We might have disruption to staffing levels or staffing availability within certain timeframes because they might not be able to access the facilities we need them to work at. We might have an increase in sort of baseline things that we're treating, so not necessarily emergency cases flooding in, but just a general change and shift in the kinds of illness and disease that we're trying to treat in those facilities. Thinking more critically about some of the events, if we're having storm damage or wildfires and floods and things, we might have damage to the facility itself or the infrastructures that we rely on to support that facility. We also might damage equipment, particularly equipment that is outside. We might lose or damage electricity supplies, so we might have intermittent electricity, or inadequate supplies of things like water or medical gases that we need in order to provide key medical services. Consequently, we might be having to manage things like ward or site evacuations. That might be from one area or the whole site. Or conversely, we might be thinking about having to receive patients from other facilities where they've been disrupted. So even if you're not within a particular area that's directly impacted by, for example, an extreme weather event, you might be impacted by the consequences. It might also impact on your ability to store medicines properly, or to manage them effectively or distribute them to where they need to go. We might also need to use more energy or more water than we would otherwise do. So we're going to be putting strain on infrastructures potentially that are already under strain because they might be damaged, but we might need more of them, for example, in a heat wave, which might then lead to issues around water quality. So it's not just an availability issue. The water that we have access to might not be of the quality that we need to be able to use it, for example, in medical uses. We might also be thinking about supply chain issues, so key things that we rely on that come and go from hospitals and healthcare facilities and health systems on a routine basis might be disrupted. So some of those things might not have an impact in the short term, but they might do if they are continuing chronically. Other things, we have very little spare capacity within the system, so if there's disruption to those supply chains, so that can include food, medical gases, medications, and so on. Those things can have an impact very directly, immediately, or might take a little while to pan out. As I mentioned earlier, there might be issues around accessing either particular areas of the site or specific facilities, or it might just be the whole site as a whole. There can be risks directly to staff and patients and anybody working within those facilities because of the specific conditions within the facilities themselves, not necessarily just those outside. And those things can all start to take their toll on the mental health of and well-being of the staff and the people that we're asking to work within them and to do things. It'll also have an impact more broadly on the requirement to monitor and survey new diseases and understand where they are within the population, how they're coming in and how they're impacting the kinds of service delivery that we need to address, which will also impact on monitoring and reporting to government agencies and other authorities who will be interested in how we're responding to those things. So as you can see, the impacts and the consequences for the health sector of climate change are many, many, many and varied. And we need to think very broadly about the way that we start to adapt to make sure that we face those challenges and reduce the impacts where we can. So we'll be having a think about how we can do that. So in some actual examples that I could find, here are some examples of healthcare impacts from recent events that have happened. Obviously, I can't speak to the causation being directly from climate change, but these are certainly the kinds of things that we can expect to start happening within our healthcare facilities if they're not already happening now. So we've got things like healthcare centres being shut down, flooding, preventing critical operations and healthcare services being delivered, people having to bring in their own water, increased in different patient demographics coming in, and also evacuations from the recent wildfires. So I mentioned just now about the way that we can start to think about the different impacts that we find from climate change. And I want to talk about shocks and stresses as being a helpful way that we can start to think about the different those different impacts. So if we start talking about climate shocks, that's generally something that we can consider a short-term or generally rapid onset kind of event, sometimes unexpected, but other times if it's a storm, we might get some warning, but we don't necessarily know exactly when they're going to happen. And they tend to be caused by extreme weather events. And they are things that therefore have a very immediate and negative impact on people and healthcare systems. Climate stresses, on the other hand, are longer-term chronic trends and pressures that tend to undermine the stability of the healthcare system and increase the vulnerability within it. So it means that we have less capacity to respond positively when there are also climate shocks levelled on top of that. So examples of climate shocks are things that we can think of like heat waves, wildfires, flooding and disease outbreak. As I say, they all tend to be these short-term, quite rapid onset events. Examples of climate stressors are things like long-term droughts, rising sea levels, changes to precipitation patterns, melting glaciers, ocean acidification and changes in seasonal timing. Obviously, depending on where you are, some of these impacts might be more general or might impact on other external factors and therefore affect you indirectly. Some of these things might affect you directly. But it can be really helpful to start thinking about shocks and stresses interacting with each other. And a really helpful diagram that shows how that operates is provided here from the IPCC, where you can see that the normal level of functionality within the healthcare system is there on the green line on the left. With the addition of climate stresses, you can see that the utility within the healthcare sector is gradually eroded. And therefore, at the time that the shock event happens, there's already a decreased stability within the system, and it means it's more susceptible to the impacts of that shock event. So you can see there's a performance drop. And then the way that we can think about adaptation is trying to take steps to prevent the impact from being, or to reduce the amount of impact that those shocks and stresses have on the system overall. So if we do very little or nothing at all, then the system will collapse. But we might recover if we take certain steps to respond to these events. But the way that we recover can be, we can recover in a variety of different ways that might get us back to a state where more or less where we were before the event. So that's that green recover to pre-event state. Or we might recover, but we might have had a reduced functionality at the end of it all, which is going to be that yellow dotted line. Conversely, we might also be able to recover in a way that actually by the end of it, we come out stronger and better than we were before. And the best idea would be that we are actually taking transformative steps to reduce our susceptibility to shock events anyway in the first place, and that we come out, in fact, far better than we were before. And the steps that we need to take to address which one of those colours we can get within our own system are going to be addressed by our adaptation strategies and the things that we do to prevent those impacts from causing harm within the system. So at this point, it's helpful to think about how do we think about that? So I know you will have been introduced to some of these concepts before. So risk being the overlap there, or the interaction between a hazard, something that can do harm to a system or to a person, and then also exposure and vulnerability. So exposure being the extent to which you have a potential opportunity to meet or interact with that hazard and the poor impacts that it has. And also then vulnerability, which indicates your sort of inherent susceptibility of either the individual or the system to the effects of that harm. So it can be helpful to think about this, the way to apply this. And this diagram I find really useful. It's from the European Environment Agency's Urban Adaptation in Europe report. And it shows here, so the top three circles there are for exposure, the climate hazards and vulnerabilities. And they all collectively together contribute then to the bottom sort of yellowy circle, which is around the climate impacts and risks, eventually what happens within the healthcare system. But we can take steps to address any one of those three or four baubles to try and lessen those impacts. So we can either take steps to address exposure, so we protect those things and make sure that certain areas are not exposed, or certain people are not exposed to the particular hazard. We can try and address the particular hazard itself, or we can try and address or reduce the vulnerability of particular populations or particular infrastructures, so that they're not as susceptible as they were beforehand. The other thing that we can do, and this is why it's important to think about, and we'll come back to this towards the end of the presentation, is to think about the impacts and the risks. So we might change nothing about the way that the system operates in advance of the incident happening, but we might change everything to do with how we respond. So I realise obviously this presentation is about emergency response, but what I want to underline is that emergency response requires you also to do things in advance to make sure you've got your arrangements in place. So generally, those things that we have in place in advance help us reduce then the impact. We speed up our recovery efforts. We make sure that we've got resources in the right place. So, as I said, the adaptation policies interventions, so if we say an adaptation intervention, we'll be talking about a particular measure that you can take to increase climate resilience by reducing your exposure, your vulnerability, or the resulting impact. So this diagram here from the operational framework from the World Health Organization is really helpful in terms of pointing us towards some of the vulnerability factors and the exposure factors that we can think about. So I think in the session that you had last week, you will have spoken about some of the things in the box on the left. So let me just zoom into that one. So these things around these vulnerability factors, by the way, they tend to focus predominantly on human health vulnerability factors. So what I want to just make sure is that when we're thinking about the health system, we need to think not only about human health and population health vulnerability factors, but also about the infrastructure health and infrastructure vulnerability as well. They also then speak about exposure. So we can think about the exposure of different people or communities, our health workforce, infrastructure, energy, water, food and health systems. Generally, they tend to take a sort of vulnerability view from this framework, tends to look predominantly at public health, and their exposure tends to look more at infrastructure and the facilities. But what I would like to draw attention to is that actually exposure and vulnerability applies both to public health aspects and to the buildings, facilities, estates, and the system that supports that public health. So we need to think about both of them. So, as I noted previously, we can think of vulnerability and exposure being affecting the building blocks of health systems. So that is when it boils down to it, we've got these central 6 aspects of the public health health systems that the WHO framework covers. So that's around leadership and governance, the workforce, information systems and ways of working. It's also thinking about infrastructures, products and technologies that support what you're trying to do, the service delivery processes themselves, and then the funding and financing that you need to think about to make sure that you can actually get those things in place and running. So human vulnerability and exposure, there are a couple of points that I wanted to draw out, which is that we need to consider vulnerability as not something that's particularly static over time. I think when we tend to look at a population level, we group people into parts of the population who we see as particularly vulnerable. So that might be the elderly, the particularly young, or children or babies, but it also might be people who are pregnant or have a chronic condition. But it's also important to think, particularly in the context of some of these kinds of extreme weather events, that our vulnerability to them will change. At some point during a heat wave, if it gets more and more hot, we will all become vulnerable to the impacts of climate change or the impacts to that extreme weather event. So when we are looking at our demographics and the way that it might impact on a particular facility, we need to take into account the fact that over time, vulnerability can change. And that we also need to take into account that an individual's vulnerability, or indeed the vulnerability of a particular element or a particular facility, will depend on the access that it has to its normal support systems. If you take those normal support systems away, which might be something that happens or is eroded through those climate stresses, then we start to take away some of the capacity within that system or that individual to support themselves, in which case they're going to be reliant on the health system to address that or to help them move on. Some points then about infrastructure vulnerability and exposure. We can be thinking about critical sites. So we can think about where within the facility we are doing really important things. So critical sites might be the server room or an instant control room or your accident and emergency centre. So there are particular spaces that we need to keep running as they should do. That often is linked to the critical processes that are that take place within them. So that might be because they are critical to the storage of medicine, for example, or cleaning processes that we need to keep hospitals and healthcare facilities running. We might also start to think about vulnerability and exposure to of critical routes. So healthcare systems are a network of lots and lots of different things that operate all at the same time. So we've got key facilities, we've got key people and goods and services, as it were. So we have patients moving around these systems, we have staff moving around these systems, we have medication. So if we cannot move people and things around those systems, then also the system itself cannot work. So we need to think about where are the critical motorways within our facilities that we need to maintain impact-free. We should also be thinking about the impact on the supply chain and that actually the things that we rely on that come externally, they have to be able to access the facility, and they have to be able to access the facility at regular times. So in what ways might those supply chains and supply routes become vulnerable to the effects of climate change or the effects of the extreme weather event? So we need to think about where all of these are in terms of the way that those risks and hazards present themselves on that key site. So again, I understand that you undertook, you had some information last week around looking at vulnerability assessments on site and risk assessments in terms of things like flooding and heat waves and how you can start to think about that. So some of the things that you might have looked at in the session last week is that you can start to undertake physical assessments. So you can model or go out live and see where flood water might go, where particular geographic features are. And that's something that various organisations have been doing. For example, JBA in Scotland has been working with NHS Scotland to do flood resilience maps for each of their sites. You might do things around looking at digital twins in order to visualise your hospital and the movements of patients and staff around the site. Again, this has been done by some of the projects in the UK. You might start to use online hazards and mapping tools. So where there's GIS data available at a national or regional level to provide information, for example, on generic understandings of heat movements or flood risk movements. But you might also take a more qualitative data analysis approach and start to approach your local practitioners. So this is really important that we start to translate anything that is, I would say, generically produced and at a very large scale, that we start to think really practically how that impacts on the site itself at a facility level site, because not all facilities will be affected equally by the same kind of extreme weather or climate impacting event. We can also start to use data from national data sets and statistics to see how historical trends and data start to look to see how that might impact. Sorry, bear with me 1 second. And we also might look at national policies and projections around climate risk assessments, either at a national, as we're on the European the climate course here today, we might also think at a European level, or we might think at a health sector level, that there might be data published and available that can help you understand what your own specific vulnerability and exposure is on any given site. So I want to now talk to you a little bit more about climate stress testing. So this is a technique that emerged predominantly from the financial sector, but has been incorporated also into sectors like the health sector. And what it does is that it considers socio-economic and political factors that influence the extent of the health system vulnerability. And it considers the factors that can affect the demands on the health system by impacting population health. So it does a certain number of things. So it's intended to try and help health systems understand how they might manage these shocks and stresses. It would help them identify the kinds of conditions where the health system might find it difficult to operate and maintain its normal service functionality. And it would also then help you identify interventions that could help you maintain that service function despite these shocks and stresses. So you're basically trying to identify the point at which it becomes unfeasible to do what you would normally do. In these kinds of tests, which really are just another way, if you're an emergency planner or an emergency preparedness person, we do exercises and tests all the time, but this is just a very large scale test that takes a step back and looks holistically at the process and the provision of healthcare across a very wide scale. So we can take a number of different scenarios when we're doing this. We can look at scenarios that involve outbreaks of new kinds of diseases. We can also look at extreme weather events. We can look at the kinds of incidents that would impact on our critical suppliers that would impact that. Or we can look at things outside the health system that indirectly affect population health and the health system running itself. So that might be things like large-scale migration associated with drought or other geopolitical issues that are impacted. So the kinds of people that we would want to involve in a stress test would include a broad range of different stakeholders. So obviously a variety of people from within the health sector itself, but also we want to be thinking about engaging with key suppliers, utilities companies, other policymakers and decision makers, people who fund what we're trying to do. We can also should really take up any knowledge and experience from universities and researchers. Obviously, I would say that, but also climate scientists and meteorologists that can help us understand how these weather events, extreme weather events, or the stressing weather events are going to pan out, and what realistic timescales are for doing that. I won't read out the box on the right in its full, but there's a variety of different kind of information that you might want to pull into this kind of exercise. So that includes various kinds of research, information about trends in the way that precipitation, heat development might pan out. We might look at different ways that people have got cover. Again, obviously, the way that your healthcare system is funded will have an impact on how you deliver services, and that will have an impact on how people choose to get access to those services or try to get access to those services in climate shocks or climate stressing events. So, as I said, I won't pick up on all of those things there, but you'll have a copy of these slides at the end. In terms of the process that you might go through if you're conducting a climate stress test, you would obviously want to prepare for that. So that's more about understanding what the scope of the exercise is. So which elements of the healthcare system we want to sort of put under stress and strain to see when it breaks. We want to understand which geographic locations we're focusing on, because obviously that's going to have an impact on the particular kinds of risks that are going to be felt in those locations and exactly how that pans out. We also need to think about the time frame. So we might look 10 or 20 years in advance, or we might only look in a very short sort of 5-year window or even sooner. So we have to choose and put a scope and boundary around that. It's important to say that we can't do everything in one big test. So you may have to do a number of these tests, one after the other, and then look holistically at what the data looks like across the piece when you add all of those pictures together. You need to form a team and have a bit of a review about existing information, so that people running the exercise and the test should be well versed in the information that's available, should gather as much information as they can do. They may need to also generate data and speak to external stakeholders at this point in order to develop a reliable exercise scenario. We also need to identify the kinds of stakeholders and participants. So from the previous slide, who from that would be best placed to be participating in that session. And then in terms of conducting the workshop itself, there's a range of different discussions that you can take to review the data and the modelling. You ask probing questions around the points at which that would put the system under strain, what the normal response arrangements would be to mitigate against some of the risks and some of the impacts that are being felt, and how that would play out over time. This can help us identify then the kinds of actions and adaptation that we need to implement. We might not know exactly how we want to address it, but we need to find a particular solution to this flooding here. And it's at that point then you can start to determine potential adaptation interventions that you could implement, and also understand an initial determination of the prioritization. So which ones you do first, whether there's any sequencing that needs to happen in terms of the different kinds of interventions that you got. And then obviously at the end, it's really important that you start to share the data from that climate stress test, so that people understand what's happening within the system, what their part is in making that system more adaptive and improve adaptive capacity within the system. So you may need to share the data and visualizations to help people understand it. You may need to create briefing materials and also state what the limitations are of the particular test that you did. And also, it's really important that if you start to allocate any recommendations or actions, that there's an appropriate governance system in place that means that action is taken and that people follow up if they have got responsibilities in terms of taking action. That should also establish the appropriate timescales for that action to be taken. So I'm very quickly going to cover some actions. At this point, I'm just going to ask Christiana, can you just give me a shout of how much time I've got left, please?
Just a couple more minutes. I think we are okay.
Yep. No problem. Thank you. So the next thing I want to think about is when you're looking at your adaptation, what does adaptation look like? And what does the future hospital look like? So this is a diagram from some work that was undertaken by Anglia Ruskin University, and they were thinking about what the hospital of the future needs to look like. So a lot of adaptation planning is about thinking in that frame. So I'm going to cover some of the interventions, or the way that we can start thinking about interventions briefly here. So we can think about interventions that act on governance and institutional arrangements. So that might be about having clear governance structures in place to make sure that plans are signed off, that you've got clear policies in place so you know where funding is coming from. That'll also link into the economic and finance category, which is making sure that you've got appropriate insurance in place, as well as programs and schemes in place to support the purchase or the implementation, the spending money of on adaptation interventions. We can also think about interventions coming under the category of knowledge and behavioural change. So this is about extending people's awareness of the impacts of climate change, but it also can impact on what people can do in their day-to-day work, but also things like emergency response arrangements and ensuring that those things people have been identified and trained out to do what they need to do in the event of something happening. And the bottom two are around physical and technological interventions that people can take, and nature-based solutions and ecosystem-based approaches. So these top ones here tend to be focused, we might call them non-structural, whereas the bottom ones tend to be infrastructure related. So although we're talking about nature-based and ecosystem solutions, those things might be, and I'll cover those in just a second, they are generally operating to impact the infrastructures and estates and facilities of healthcare systems, whereas the top three boxes in the non-structural section tend to focus more about the people and the arrangements that govern what they do. The other way that we can think about them is as being either proactive or reactive. So proactive things are things that you can do to take steps in advance, or that you should be doing in advance of a particular event happening. And reactive are things that you would have in place so that when that event happens, so when there is a storm or when there's a flooding event or a wildfire, that those things are in place. And for me, it's really important, I think, that we start to think in this sphere, in the proactive and structural way, particularly around adaptation. It's really important that we think in advance, because a lot of these structural interventions that we might want to take can take time to implement. But if you implement them well, mean that you will have less impact that you need to react to reactively, if that makes sense. So that kind of physical adaptation that I'm talking about involves things like green roofs, improving your drainage and water management systems, incorporating nature-based and plant solutions to do things like sheltering and screening. But those screens can also be man-made structures and manufactured structures. We might think about ways of ventilating hospitals in different ways of collecting water. But we've also got things on the right there where we might think about installing things that make recovery easy. So thinking about how we do cleanup. If we know that we're going to repeatedly flood in this particular area, are there ways that we can design things that drain better or that are easily cleanable and we don't have to rip out and start again? Are we putting in redundancy or backup systems? Are we building in reconfigurability so that we can make our services be delivered in different places, either at short notice or over time? all of these things we can start to be building into hospitals and their infrastructures, either in refits or if we're building new hospitals, we can start to be making decisions that can start to incorporate some of these things. So I won't talk too much around policy landscape, but the decisions that you make will be heavily influenced by the kinds of things that are available to you at a national health sector or organisational perspective, depending on what your own particular arrangements look like. So you'll need to understand that quite heavily before you can start to make choices. And another way that you might want to think about when you and looking at adaptation interventions, there might be a number of different ways that you can address the risk that you've identified, or the exposure or the vulnerability that you've identified. And you need to make a choice between which kind of intervention you want to take. Adaptation pathways can be a really helpful way of doing that, because they look through the sort of sequencing and the points at which they stop becoming effective, or the extent to which they can remain effective. So do have a look at that if that's something that you are struggling to start to pick your way through. So just summarising up then, when we're thinking about adaptation and climate resilience in healthcare facilities, when we're thinking about that in the context of these short-term shocks or long-term chronic stresses, we can start to think about them as interacting with a lot of different factors that are external to the healthcare system. So not just climate risks, but other non-climate driven risks. We can also think about the impacts on other sectors outside, and that the health sector is impacted by those direct and non-direct risks, and that we need to take a systems approach. And in summary, these climate-driven risks interact with other risks and mitigation strategies. They impact not only on human health, but on the way that the system is designed to provide service delivery. Climate stress testing can help you identify the tipping points of failure and the kinds of relevant interventions that you need to make. The interventions that you might want to take could be structural, or they can be non-structural and relate to people and their behaviour and their processes that you're doing. Adaptation pathways can be a really useful method to help you pick your way through that. But adaptation itself is most likely to be effective if you're thinking about taking a holistic approach and looking at everything. If we take transformational rather than incremental approaches, so we're not doing things in an ad hoc, small way. And if we can start to think about proactive controls, then that means that the reactive controls that we have in place, particularly around emergency response, are less likely to need to do all the heavy lifting. We should have reduced the impact already, so we'll be less likely to be impacted. Okay, at that point, I'll hand back to Christiana. Thank you.
Thank you very much, Dr. Elstow. This has been a very interesting presentation, very comprehensive. We do have a few questions from the participants. I will choose maybe one or two. So the first question is, do you have examples of real climate stress tests conducted in the past?
I mean, yes, they have been conducted in the past. There's various literature around climate stress tests, so we can provide some examples of that. I'm not sure what the person is asking for, though, as a response in terms of what, other than yes or a no. They have been conducted. They have.
And I think that some of the case studies that we will see in a bit might provide some examples of that. Another question is thanking the attendees, thanking you for the presentation, which is very informative. And the question is it possible to carry out surveillance and preparedness audits on health systems using the tools and methods you have spoken about? If so, are there standards that the health system can use to prepare, or do they need training on these too?
So I think training is really important. In all of these things, we need to have awareness of the different methods that might be available. There are a variety of different standards, international standards that might be appropriate here. So there's various different ISOs available for climate resilient infrastructures and things like that. So there's probably not a one size fits all answer here. It will really depend on the kind of tools that you need need for the kind of risks that you're looking at. So if you are looking at flooding risks, there are specific tools that you can use for that. There are particular consultants that will be and engineering companies that might be able to help you do that. Again, if you're looking at using AI tools and things like digital twins, there are things that you can do. That's a relatively novel way of approaching this project, this kind of thing. So it's really about bringing together the expertise that you've got into the right place and understanding where you might need to explore and work with external partners who have a particular expertise about the risks you're facing. That's why everything that you should be doing in this space should be driven by what are the risks that we're facing and how is that going to impact on the particular facility.
Great. Thank you very much. I think we need to proceed with the next presentation, if that is okay. So to move on, it gives me great pleasure to present our first case study presented, Dr. Maria Libura. Dr. Libura holds a doctorate in medicine and health sciences. Her research interests are focused in two areas. The first is health inequalities and the mechanisms of exclusion from medical care. And the second is medical and health communication, in particular, the cultural perception and media and portrayal of health issues. She's also a regular contributor to various media outlets in Poland, writing comments on topics related to social solidarity in health. Dr. Libura is a member, founder, and vice president of the Polish Society for Medical Communication. She's also a member of the Polish Society of Human Genetics and the Polish Network of Economics. She has been a recipient of scholarships from the Fulbright Commission, the Stefan Battery Trust, and the Foundation for Independent Polish Literature and Culture. Dr. Libura, the floor is yours.
Thank you. Thank you for having the chance to present the case study of a small hospital in Nysa. And as you have heard, it will be a slightly different perspective from what we have just heard. And I think it will nicely complement my predecessor. It's perhaps the greatest challenge which comes with climate change and healthcare is that the mindset is one of the greatest vulnerabilities that we have, because climate change resilience starts with belief systems of decision makers and general public. We may have all the instruments at hand, all the plans and forecast, and still fail to implement correct action. And this is the story of the hospital in Nysa. So in this short case study, I'm going to tell you about the first flooding, the so-called Millennium Flood that devastated southern Poland. Then I will briefly explain why the hospital in Nysa, which was flooded and suffered heavy losses, was not relocated to a safer area, but renovated and actually expanded in the very same flood-prone spot. And then look at what happened last year when another disastrous flooding occurred, and the consequences, or perhaps rather lack of thereof. You might have heard of the Millennium Flood in Poland. Actually, it was the basis of a highly popular series on one of the streaming platforms. And in fact, it was much worse than what you see in the series. So these are the pictures from Wrocław, the city which was really, really badly affected by the Millennium Flood. And in fact, it caused damage that took more than 2 decades to recover from. And among the facilities that were very badly affected were hospitals in Wrocław and in other smaller towns, but Wrocław being a big city, totally covered underwater. In some places, the water reached up to the 6th floor. So that is what actually caught popular imagination. But that was the last century, right? And you may think Poland was just trying to reach the developed world, was still trying to get into the European Union, and you might think that the poor country was just struggling because of lack of resources. So what happened was that the hospital in Nysa was at that time so affected that the not just the basement and the ground floors, but some of the patient wards were also flooded with water. So all the medical equipment on those floors was damaged. There was total power outage, as you may imagine. The heating systems were out, and also patients were left without food or medicines. So 170 patients had to be evacuated, and it turned out quickly that theoretically there were 25 stretchers, but the emergency workers were able to find only 7. So they had to be quite creative, and they used mattresses and to make makeshift stretchers, and those that were critically ill but still had some power in their hands were actually asked to hold their IVs up above themselves during evacuation. Pregnant women were evacuated using pontoons. So very dramatic and traumatizing experience that actually changed very little. Because the hospital was not relocated, you might think that this kind of event would force the local authorities, medical professionals, and the general public to actually demand relocation. But what happened instead was that the hospital was restored and even expanded. And why could this happen? So one thing is the costs. So you might think that Poland at that time was not yet the recipient of EU funds, and relocating the hospital sounded like a huge investment. Also, lack of political will and public support. So the residents of the city actually liked the localization. So they enjoyed the fact that it was in the city center, and everyone recognized this place as the place where they could get help. Also, when you think about risk assessment, at that time, the belief was that it was, as it was called, a millennium flood. So nobody believes that anything like that could happen within the next generation. And so the lack of imagination made the risk assessment as if made people to underestimate the risk of recurrence of a similar event. And also there was a false sense of security, because some actions were taken by the central and local government to help prevent future flooding. So embankments were strengthened, there were new dams built, and it points to another huge problem within the healthcare system and climate change. So in healthcare, decision makers tend to think that climate change is actually someone else's problem. So let's leave all the security measures to the engineering department. So those who are responsible for different type of infrastructure. We are mostly concerned with providing healthcare services, and it is not our problem. Let others do their job. Let other services, other governmental departments take care of securing our operations. So we can say that is a crisis of imagination. So it's not just that we don't have the right measures or we don't have funds to relocate hospitals. It's a lack of imagination. It's a crisis that actually led to another huge tragedy that happened to the very same hospital. And here, these pictures that you see now are pictures not from the 1997 flood, but taken last year in southern Poland. Not just Poland was affected. You are probably those of you who are from Europe or perhaps watched news on TV, you might recall that last autumn, this part of Europe was severely affected by a low pressure system known as Boris that brought record-breaking rainfall to Central Europe. And it caused water in levels in the Nysa River to rise sharply. And in fact, we know from the measurements that the water level in Kłodzko on Nysa River reached nearly 8 meters. 8 meters. And so in fact, it was 1.5 meter higher than the level that was measured in 1997. So actually, the water level was higher than during the so-called Millennium Flood. And theoretically, as it is still under investigation why what happened, because theoretically, all the security systems in place should have withstood this high water. But there was, as it happens during such dramatic events, there was a series of coincidences. So one of the dams upstream actually broke, and you can see the results on the picture. That was what happened in Włochałasy, and then there were fears that actually the flood water may affect the big city of Wrocław again. So some people, in central government decided to start shedding water from the Nysa, the retention basin, but nobody really, it's still under investigation how it happened that despite all the prognosis, Nysa became flooded again. So reflooding of the hospital caused huge damage. So the damage was actually much bigger than what happened during the Millennium Flood in 1997. So even though there were certain improvements, the hospital critical infrastructure couldn't be safeguarded against flooding. So the emergency department came underwater. Many diagnostic equipment was actually placed on lower levels, including the basement. So the entire medical lab was flooded. CT and MRI were flooded. So the damage done far exceeds that the hospital suffered in 1997. And it may sound paradoxical that when you think of it, it's not, because once you think about how the medical technologies advance, you will easily see why more and more expensive medical equipment translates into much higher costs of underestimating this type of risks. But also there was a huge impact on patients, because there was another urgent evacuation that was necessary, especially for intensive care unit patients. So rescue workers were actually withdrawn from the action, from where they were badly needed because people were losing their homes, waiting for rescue, and they were directed into the hospital. So the hospital, which should be a center of help and provision of healthcare under such crisis, became a challenge, an additional challenge for rescue forces, rather than being a valuable resource needed in time of crisis. And let me just add that this is what climate change is about. So one of the issues that is heavily underestimated, and not just by climate denialists, but by almost everyone, is that we have now experiencing this rapid cycling. So extreme events that were once thought as very rare are occurring more frequently, and they tend to be more intense. So as with the last flooding, which was much worse than the millennium flooding. And when you think of it, if a flood like that happens one in a century, in some wicked way, it may be thought of as a kind of force majeure, an event that forces the city to modernize, to rebuild in a better way. But if events like that are occurring at like once in a decade or once every 15 years, they no longer serve this role, and that should change the mindset of decision makers, and perhaps also it should change the very legislation that, for instance, governs where hospitals can be built and what kind of standards such locations should meet. So clinging to past assumptions is sometimes the biggest obstacle that undermines preparedness for new changing climate reality. And on the very ending note, let me just add that I'm not sure whether this event will actually lead to change of localization and to moving the hospital into a safer place. Because when you look at the Facebook page of the hospital, you see that actually this kind of dramatic, traumatizing event brings short-term gains in terms of spotlight on the hospital. And in fact, they are able to raise money for reinstalling our lifts, buying new MRI, and each such event is then posted and publicized on social media, which brings more attention to a healthcare facility that otherwise is just taken for granted and nobody really cares for it. So when thinking about climate change and building resilient healthcare facilities, we also have to take into account that there are very strange, unexpected side effects, and that some what is a long-term risk may seem like a short-term gain, especially on the local level, and that leads to very wrong decisions. Thank you.
Thank you very much for that presentation, Dr. Libura. So if you have, we have some time for a couple of questions. So the first question is, the medical and caregiving workforce is often one of the most stable and enduring populations in a community. How have they preserved the memory of these events, influenced decision makers' assumptions, and shared policies? And what does this impact look like in the post-2024 landscape?
So the answer is not as simple. But when you read the diaries of rescue workers from the Millennium Flood, and you have quite many accounts of the last flood. There was this dramatic event in which one of a very famous and very good physician actually died when driving back home from one of those badly located hospitals. So those memories are there, but then when it comes to decision making, very different factors kick in. Right. And I think that most people just know that what we really need to work on is on communicating that these events are not once-off events, and that this is the biggest challenge, and even past experience is not enough. Even personal past experience is not enough to change the mindset.
Thank you very much. And very briefly, how can technology be used to improve emergency response and predict climate effects? What are the key components of a preparedness plan? I know it's a very general question, but maybe you can narrow that down to your experience with these specific disasters.
Right. So, in the past, I mean, you could think that moving because there were, like paper patient records, you could move them upstairs. And if you think about what happened after 1997, I mean, it's a pity that nobody took such measures as relocating the hospital lab into some higher ground. Right. So these are very simple measures that didn't really require any advanced technologies to be implemented, and still they were not put in place. And what we heard earlier, so like having a hospital twin, I mean, it's great, and because healthcare data and your personal data are becoming a really, really important thing. But in the end, what you need is really, tough regulation on where hospitals can be localized. Rather than allowing local communities to play with people's lives, because even your healthcare data are protected, or equipment is protected, and patients are evacuated, holding up their IVs. I mean, priority is always a living human being. Having in mind how important other things are.
Thank you very much. I see a hand up. Is it a question, a comment?
Just short comment, because I'm a colleague of Dr. Maria Libura from Medical University of Gdańsk. And just one thing, yes, so what shows us this crisis is that we still lack the human aspect of preparedness. I mean, there was no problem with the volunteers, yes, but just these volunteers were not prepared for that purpose, that were not trained before, yes. So I think it's also the time that we should adopt in this regard, to prepare people to face such a problem, such as crises, by good training. Yes, so that's just one comment, which is, I think, the obvious outcome.
Yes. Thank you very much. So moving to our second case study and third presenter of the day, Dr. Stav Shapira. Stav Shapira is a senior lecturer and former head of the master's program in emergency medicine at the School of Public Health, Faculty of Health Sciences, Ben-Gurion University in the Negev. She's currently a visiting scholar in the Department of Epidemiology and International Public Health at the School of Public Health, Bielefeld University, Germany. Her research focuses on disaster resilience, disaster epidemiology, and the health and social care needs of vulnerable populations during crisis. Dr. Shapira's current work examines climate-related health risks, behaviors, and needs among vulnerable populations in Israel, mapping the strengths and gaps of local communities and healthcare institutions to inform strategies for building a climate-resilient health system. She employs mixed methods and community-based participatory approaches to translate research into actionable policy and community-level change. So, Dr. Shapira, the floor is yours.
Thank you so much, Christiana, for the lovely introduction. So I'll just share my screen. 1 second and you'll be able to see the entire slide. Okay, so I hope everything is okay now. So again, thank you very much for the lovely introduction, and I'm very happy to be here today and discuss with you a case study about the intersection of climate resilience and healthcare in Israel. So just to give you a very quick glance, we have about 15 minutes. So first, I'll provide a very short background on the system, on the healthcare system in Israel and its climate-related vulnerabilities. And then we'll examine together resilience from both national and local perspective. And finally, I'll share some policy recommendations and practical strategies to enhance climate resilience. So let's start. So before diving into the impacts of climate change on healthcare resilience, it's important to understand the foundation of Israel's healthcare system. So Israel operates a universal, publicly funded healthcare system that ensures access for all citizens, primarily through 4 health maintenance organizations, or HMOs. So while the system is highly centralized, we also have centralized and predominantly public, important to say. We also have a growing private sector that plays a complementary role. Israel consistently achieves world-class health outcomes, including high life expectancy and low infant mortality rates, thanks to advanced medical technologies and a strong primary care network. However, we do have some systemic challenges, which I'll detail in the next slide. So Israel's geographic and demographic characteristics make it especially vulnerable to climate change, creating significant challenges for its healthcare system. So first, as a climate hotspot, the country experiences diverse climate zones from arid deserts to Mediterranean coastal regions, with about 17% of its land classified as either arid or semi-arid. And this variation increases exposure to extreme weather events, to heat waves, to air pollution, and affects water and food availability and quality. In addition, high urban density in central areas of the country amplifies the heat island effect, which I'm sure most of you know, while rural and peripheral communities face gaps in healthcare access. Additional resource constraints, including workforce shortages and high energy dependency, pose additional risks to healthcare operations. So these vulnerabilities contribute to rising climate-sensitive health risks, such as heat-related illnesses, vector-borne diseases like the West Nile fever. We just had a big outbreak last June with over 30 fatalities. And also challenges in disaster preparedness for extreme weather events. And I will discuss and elaborate on this more in the next slides. So this presentation follows a structured approach, moving from a national to local or institutional perspective. And the analysis which I present today is based on a mixed methods approach, combining data from a nationwide survey, population survey of almost 1,500 participants. We oversampled ethnic minorities and peripheral regions in Israel, and also 25 semi-structured interviews conducted with key policymakers, administrators, and managers from the Ministry of Health, from hospitals, and from Israel's health funds. And these reflect diverse organizations, geographic regions, and levels of responsibility across the Israeli healthcare ecosystem. This section was led by a brilliant student named Irit Lador, which I believe is in the audience today. So thank you, Irit. And by integrating these different perspectives and methodologies, we aimed to understand what are the essential steps for building a climate resilience health system in Israel. So moving on straight to the findings, this slide will summarize key findings from the qualitative interviews and will identify both barriers to climate resilience and facilitators that can support adaptation. So at the national level, several systemic barriers emerge. First of all was the absence of a clear policy framework. Currently, there is still no government-led strategy integrating climate adaptation and mitigation into the healthcare system. The second one was the lack of emergency protocols specific to climate-related health risks. So while we do have these frameworks for conflict-related events, for earthquakes, and for other large-scale disasters, no such coordinated response exists for extreme weather events. And third, the issue of significant funding gaps. So without dedicated financial support, even well-intended regulations lack impact. And last, that in the absence of national policy and resources, healthcare organizations either do not act at all or act independently, leading to a very fragmented bottom-up rather than a coordinated top-down response. So beyond the national barriers, we also found that climate resilience remains mainly deprioritized within institutions, with responses often reactive rather than proactive. We found that leadership engagement in this area was very limited and that awareness among healthcare professionals was low, with very clear gaps in education and training on climate-related health risks. However, we did reveal several key facilitators that could help enhance resilience. So first and foremost was the issue of economic incentives. So for example, several hospitals adopted energy-saving projects, such as solar panel installations, primarily to reduce costs, but these initiatives can also enhance institutional resilience to climate change. Second issue is leveraging existing emergency preparedness frameworks. So Israel's experience in handling conflict-related crisis and earthquake preparedness offers a strong foundation for improving response to climate-related disruptions. So for instance, we do have a lot of discussions right now about reinforcing electrical infrastructure against missile-related power outages, and this could also apply to outages caused by extreme weather events. And finally, a very critical facilitator is the issue of appointing a dedicated role of a climate resilience officer within a specific institution or organization with clear accountability for advancing climate resilience. So this assigning responsibility ensures that climate risks are prioritized, monitored, and acted upon rather than being sidelined. But this was mainly not the case in most institutions reviewed or interviewed. So based on these findings, this slide outlines some key policy recommendations aimed at enhancing climate resilience. They are directly derived from all the barriers and facilitators I mentioned, so I won't go in much detail, and I'll also touch more on policy recommendations towards the end of the presentation. So while we discussed so far systemic and institutional resilience, it's equally important to examine how climate change affects individuals, especially vulnerable populations, and how these impacts intersect with the healthcare system. So the next few slides will present findings from the National Population Survey in Israel we conducted, focusing on climate resilience, vulnerability, and gaps in healthcare access. And these findings highlight some key stress points within the healthcare system, which align with the challenges addressed in climate stress testing, like Louise discussed in her main presentation. So understanding these vulnerabilities allows us to assess where healthcare system may struggle to maintain essential functions under climate-related shocks, and what interventions are needed to improve resilience. So this slide maps climate resilience in Israel using the IPCC framework that also was discussed in the main presentation, so I won't go over it again. So we're talking about vulnerability, exposure, and hazard. Our survey assessed multiple indicators for each of them, and these are visualized here as composite indexes. So we can see a very clear pattern that emerges in which peripheral regions, north and south of Israel, which are also characterized by lower socioeconomic status and higher ethnic minority populations, consistently rank high across all three measures. And this highlights their heightened susceptibility to climate-related health risks and underscores the need for targeted interventions to enhance healthcare resilience in these high-risk areas. So some additional findings from the survey. In this chart, it shows responses to the statement I have good access to healthcare services. And you can see that respondents in the center of the country reported the highest level of agreement, while those, again, in the north and south peripheries were more likely to disagree, indicating significant geographic gaps in access to healthcare. In the right chart, it illustrates the percentage of respondents who missed a medical appointment due to extreme weather. And here we see a clear trend. Individuals in the north and south peripheries were significantly more affected compared to those in the center, reinforcing the idea that peripheral regions are more vulnerable to climate-related disruptions. And this needs to be acknowledged by healthcare policymakers and by local health institutions in this specific area. Delving a little bit deeper into vulnerability assessment, this graph shows that Arab respondents, which are the largest, Arabs are the largest ethnic minority in Israel, consistently reported higher rates of missed medical appointments due to extreme weather compared to Jewish respondents, and this is across all income levels. So while higher income reduces disruption for both groups, the gap remains, again pointing to the structural inequalities. And these findings emphasize the need for targeted policies to improve climate resilience in historically underserved communities. So as I move to the final section of this presentation, which is based on the work of one of our master's students in Ben-Gurion University, Liran Raz. Liran is also a senior manager at Barzilai Medical Center, the second largest hospital in the Negev region, the desert Negev in Israel. So his project on how to improve institutional resilience to climate risks serves as, to my opinion, a great example of how academia and particularly schools of public health can bridge the gap between research and real-world practice and to inform institutional climate resilience planning. So based on his work, these slides outline key strategies to enhance the preparedness, the response, and resilience of healthcare institutions in the face of climate change. So the first priority is risk assessment, which involves mapping and identifying climate-sensitive populations in advance, utilizing retrospective data from the hospital or from the institution itself to anticipate climate-related health risks. Next is the issue of infrastructure resilience that must be enhanced. So hospitals should improve energy efficiency and aim for energy independence to enhance adaptation, but also to reduce carbon footprint. And another issue, which is highly crucial in Israel and especially in hospitals located in the Negev desert, is expanding shaded public spaces to mitigate or minimize exposure to heat. And finally, I can't stress enough the issue of education and training of health personnel. So raising awareness about climate-related health risks and ensuring that healthcare providers can identify, manage, and treat climate-related conditions will be the key to building long-term institutional resilience. So to manage extreme weather events, healthcare institutions must expand surge capacity and implement early warning systems to track weather-related extreme events, such as heat waves, floods, and disease outbreaks. And of course, that beyond institutional preparedness, multi-sectoral coordination is key for all of these strategies. So collaboration between the Ministry of Health, the meteorological services, local authorities, and community leaders ensures an integrated response. And additionally, public education programs proactively should be expanded, prioritizing vulnerable populations with culturally sensitive communication strategies. So these insights from Barzilai Medical Center highlight the shift from a reactive response to a more proactive climate adaptation, offering a model that can be scaled across healthcare institutions in Israel, but also beyond. And just before concluding, I just want to highlight the incredible team behind this project or projects. You can see their names and affiliations here, and to acknowledge the collaboration, the collaborative spirit that drives this work. I'm very grateful to be part of this team. And just to say thank you.
Thank you very much, Dr. Shapira. So a very interesting question was posed And given also your role with academics being program coordinator, how do we implement all these emergency preparedness in medical schools and other programs for healthcare professionals?
So I can only speak, as my role, I was the head of the master's program in emergency medicine in Ben-Gurion, now led by Professor Dorit Nitzan. But we really try to involve our students in these kinds of projects, in real-world projects, keeping a close connection with health institutions and policymakers to understand what kind of problems are real-world problems and how can the research be conducted based on real-world questions. So I hope this will, this kind of enhances implementation and supports implementation of research findings and help bridge the science policy gap that we all know from many other fields. So yeah, this is what we're trying to do.
Thank you. And another question, would you recommend that each hospital has somebody who is in charge of climate resilience for that hospital, or would that position need to be more system-wide?
Both.
Okay.
First of all, we need someone at the national level, at the Ministry of Health, at each county level, but also within each institution, because if you have an officer which is directly responsible to climate resilience, then things start to move. This is what we see in Israel. Most of the institutions don't have this kind of role, and we see the difference between those who have and those who haven't or doesn't.
Perfect. Thank you very much. I think it's time to conclude. I want to thank again all three presenters. I think that we have, I enjoyed very much both the presentation and the case studies. I want to thank everyone for being here. I encourage you to look more into the session material, and some of the presenters also included interesting links in their presentations. I encourage you to visit those as well. And above all, please don't forget to complete this post-session survey. You can scan the QR code with your phone camera, or if you're part of the WhatsApp group, you can find the link in the chat. If you're not part of the WhatsApp group, this is your gentle reminder to join it. Thank you very much. Again, thank you to all the presenters. Amazing content presented today. And I wish you all a great afternoon or great night or morning, depending on where you're located. Thank you very much.